Hello and welcome to Health Professional Radio. I'm your host, Neil Howard. Thank you so much for joining us for another segment. In this segment, we're going to be speaking with Dr. Angela Stoer. She's an OBGYN, and she's joining us to address how the pandemic has exacerbated the opioid epidemic and the need to refocus on non-opioid pain management approaches after surgery across several procedures, especially those procedures in women's health. Welcome to Health Professional Radio, Dr. Angela Stoer.
Thank you so much for having me.
You're an OBGYN. Was that your first love in medicine?
Yes, to some extent. I actually thought I wanted to be a pediatrician coming into medical school, and then discovered I really liked the procedural work that was associated with OB. Now I predominantly do gynecology.
Now, you deal with a wide variety of women's issues, from sexual dysfunction, pelvic pain, all sorts of things. Last month, around about October the 19th or so, a group of women in healthcare joined forces to talk about how the field of women's health is severely falling behind. I believe it was the Future is Female event. Could you talk about this event and some of the topics that were discussed there?
Sure, absolutely. Yes, it was called the Future is Female event, and it was a handful of providers from different backgrounds. There was a pelvic floor physical therapist and someone who does breast surgery. And then myself, I'm a pelvic and sexual pain and sexual dysfunction specialist. So there was just kind of a crew of us that all talked about the ways in which women's health is underrepresented, underloved, shall we say, and some of the things that can be done to sort of encourage women to take action for their own health, to be their own advocates, as well as encouraging medical providers to do a better job.
Now, you're extremely passionate about refocusing on non-opioid pain management. What is it about non-opioid pain management that excites you so?
Well, there's a couple of different things. The reason I got into it to begin with actually is from a personal experience. My husband and I had a hockey player that was living with us during the junior leagues, and his two best friends overdosed in between his first and second year staying with us. And when we had actually met those boys at a graduation party and were absolutely shocked. So they didn't live that far away from us, about 4 hours. And so I couldn't get it out of my mind that a prescription that I had written might have been in the bowl of pills that the kids were taking at that party. Most patients that overdose, it's from a diversion of a legitimate prescription or from a prescription that they were given themselves by a provider. So that's why I became passionate about it in the first place. But now, as a pelvic and sexual pain specialist, a lot of times my patients do dramatically better if I can keep them off of narcotics. And there's multiple reasons for that. I'm not sure how much detail you want me to get into.
You can get into as much detail as you think our listeners would like, to get as much information as we can.
Sure, absolutely. So as in talking to medical healthcare professionals, there's a couple of things to know. A lot of us in healthcare do know that chronic use of narcotics is not super helpful, mainly because people develop a tolerance to narcotics and require larger and larger doses. The little known fact about that is actually that happens acutely as well. So when we treat acute pain, even for like post-surgical reasons and other times that we would normally use narcotic pain medication, it does create kind of a stair-step approach to the problem. When you give the pain medication, initially the pain scale may be at a 5 or so. The pain medication will work, the narcotics specifically will work, and the pain will go down to maybe a 2. But when the medication wears off and the narcotic rebounds, the pain goes up higher than it started at, maybe a 7 or 6 or 7. And so the patients keep having to take more narcotics until the initial insult is kind of overcome. So for surgical procedures, it usually takes about 5 days for the incisional pain to go away, because that's how long the inflammatory response lasts for an acute injury like that. And there are ways to reduce pain without needing to use narcotics so they don't get that higher and higher dose problem.
We hear about the pandemic every day, but none of the other situations have gone away. People have stopped going to the doctor, a lot of visits because of fear of contracting the disease. How has this exacerbated the opioid epidemic? I mean, we don't even hear about the opioid epidemic like we did 2 years ago. It's not gone anywhere, though.
Oh, gosh, no. I think it's probably actually gotten worse with the pandemic. There are a couple of reasons for that. Number one, patients that were already at risk of having opioid tolerance issues or that have access to opioids now are oftentimes anxious and depressed because of the pandemic. And it's not necessarily COVID itself that's the problem. but social isolation, people who were previously functioning members of society are now jobless. There's a lot of different reasons for patients' mental health to be unstable right now, and you throw a little narcotic onto a patient who's not completely mentally stable, and you have got a big problem on your hands. So that's definitely one thing that has, I think, worsened over the pandemic. The other thing that may be a little bit better, if you want to say it this way, is because we haven't been doing as much surgery. There's not as many narcotic scripts being written. So it may be evening out a little bit. One thing, though, that I will say has drastically affected medical practice with the pandemic in relationship to just surgery in general is that we're doing more surgeries as outpatients now. And mainly reason for that is we're trying to get patients in and out of the hospital to reduce the need for hospital beds because those are being taken up by patients so much sicker. So elective surgeries have almost completely gone to outpatient, even major surgeries like hysterectomies. And using non-opioid approaches is significantly better for a very prompt and quick recovery in the PACU as well as for the patients at home.
I've got a bit of experience with surgery, myself and also others who've undergone surgery. You come home and you feel, okay. You've got that anesthesia happening. You've got your prescription of pills that you're going to take, after a nice meal or whatever. But that second night, that third day, the pain, it starts like, hey, it's really starting to feel like I've, been under the knife. What have you been using to kind of alleviate the pain during some of these major surgeries in women's health, and also helping with that pain after the surgery, those few days when it may be, some of the worst pain?
Sure. So a lot of people that are fairly passionate about reducing narcotics are going to really forward ARIS protocols, which is enhanced recovery after surgery. There's a lot of data out there that shows using these enhanced recovery after surgery protocols significantly reduces time to recovery, as well as improving things like constipation and drowsiness, nausea, things that are associated with longer term recoveries. So using a really strict ARIS protocol is super important. That includes things on the front end before patient gets to surgery, making sure their patients are in as tip-top shape as you can make them, making sure diabetes is under control, that they quit smoking. And then around the time of surgery, having the patients do dosing protocols prior to the operating room, doing carbohydrate loading drinks, taking acetaminophen preoperatively, as well as doing gabapentin, reducing nausea with stuff like scopolamine patches. And then intraoperatively, for me, I do the best I can to make my procedures as short as possible without sacrificing the technicalities of the surgery. So doing it as quickly as possible safely. But also there's a couple of tips and tricks. I use a long-acting injectable non-narcotic into my incisions, and my anesthesiologist often will use tap blocks for me if it's an open procedure or a C-section. Those long-acting products, Exparel is the one that's out on the market right now, is the one that I've been using. But using some type of a long-acting injectable anesthetic significantly reduces the need for narcotics and also significantly improves pain control in the immediate postoperative period. But also specifically for gynecologic procedures and even really for GEMS surgery, you can reduce your abdominal pressure as low as you can to still be able to see, which significantly improves some of the muscle discomfort that patients get on the back end. There's also things to be doing after surgery, taking scheduled NSAIDs and scheduled acetaminophen, as well as scheduled gabapentin, which is a nerve-type blocker. Those using consistently are really helpful in minimizing the amount of narcotics and also kind of preventing that second and third day rebound of pain.
Well, if you would give us a website where our listeners can learn more.
Sure. WeAreWomen'sHealth.com is a great one to look at, and there are several others that I think are linked through their website, so that's probably the best place to start.
Well, Dr. Storr, I appreciate you joining us here on Health Professional Radio. It's been a pleasure speaking with you.
Absolutely. Thank you so much.
You've been listening to Health Professional Radio. I'm your host, Neil Howard, in conversation with Dr. Angela Storr. Audio copies of this program are available at hpr.fm and healthprofessionalradio.com.au. You can also subscribe to the podcast on iTunes, listen in, download a SoundCloud, and be sure and subscribe to our YouTube channel at youtube.com, Health Professional Radio.